This is just another poster that we've done in the context of, our sort of UK national CAR-T cell panel. This is, we've sort of got a CAR program across the UK. We've got sort of 10 treatment centres. And we were very interested, we're all comers to this panel. If they fulfil the eligibility criteria, they get a CAR-T cell on the NHS. And we were interested to see, just to try and unpick who's responding and who's not, because, of course, this sort of 60% of patients who don't get a response, we need to try and understand who they are so that we can improve their chances. And I think we probably suspected at the national panel that maybe some of the patients who would be deemed unfit for an autologous stem cell transplant might be a group who potentially were not doing as well with CAR-T. Because, the patients who aren't eligible for a stem cell transplant are usually older patients. They're often patients with comorbidities. They perhaps don't have very good cardiac function or renal function. And so we sort of explored that question in our data set. And we actually found that, in all of the patients that we treated, with sort of over 400 patients approved in the UK, 20% of all those patients would be considered unfit for autologous stem cell transplant. So, and those are patients, the majority of them were just too old for the procedure. So that's over the age of 70. A few of them had issues around frailty and performance status, or impaired cardiac function, renal function. And so all of those patients, the 20% of that cohort, 65% of them actually got to the infusion. So that means that 35% of those older and unfit patients didn't get there. And the majority of cases, that was down to progressive disease. And that's always the commonest reason why patients don't get to CAR infusion. And so the dropout rate for those unfit patients was 35%. And that compares to the 24% in the autologous transplant fit cohort. The dropout rate was obviously higher in the unfit cohort. So that's something certainly for us to look at in more detail. And when we looked at those patients, certainly the performance status, it was usually higher than the fit cohort. So more of those patients had an ECOG of 1, which means they're really only capable of very light work, versus those patients who are fully independent. And they usually had a higher risk sort of IPI score, and they often had a lower glomerular filtration rate and ejection fraction. But actually, when you looked at the outcomes for these patients, so we're sort of feeling fairly, this is going to be a high-risk patient group, but actually they did quite well. So at 6 months, the overall response rate in those patients, those autologous transplant unfit patients, it was actually 41%. So, and that wasn't really different at all from the patients who are fit for transplant. So if you can get an auto-ineligible, sort of unfit, frail patient to the point of infusion, they actually seem to do just as well as the patients who are sort of fit, perceived to be fitter and certainly fit for a transplant. So that's encouraging. Because, of course, this is a terrible sort of unmet need. These patients who've got refractory high-grade lymphoma and can't get to autograft. So if we can deliver CAR safely to those patients, then that's really a sort of a huge advantage for them, a potentially curative therapy for this population. And in terms of the toxicity, that was the other big concern we had. If you have all these other comorbidities, is the toxicity profile going to be worse? And in actual fact, the toxicity was comparable to what was seen in the fit group. So in conclusion, I think this was a very encouraging piece of work that we did within the national panel that supports the hypothesis that we should be offering CAR-T to our older, less fit patients, because actually they can do pretty well from this therapy and don't seem to suffer more in the way of side effects than their fitter counterparts. And I think that's a huge medical advance for these patients.